Hello, dear colleagues. Can you hear me? Can you see me?
Yes, you are visible, you are audible.
Thank you very much. So I am really happy to be here. Unfortunately, I can hear the echo, but I guess it will not be a big problem. Okay. So as my colleague, Dr. Sunavar, already introduced my talk now. Sorry, it's like a really strong echo. Maybe you can make some fix on IT.
You can't move the slides?
No, I can, but it's a really loud echo.
Oh, it's echoing.
Yes.
Is it okay now?
I will try. Now it's better.
All right, please.
But still, I can hear it. But okay, so let's continue not to waste the time. So I'm very happy to be here. Thank you, dear respectful doctors, colleagues. And I would like to introduce our vision on advanced lung cancer care through comprehensive genomic profile. So I'm Dr. Shur, yes, so I'm working at CeGaT, it's a German company located in Tübingen. And we will talk on my slides. I cannot, yep. So about some disclosures, yeah, so this presentation will be about more educational purposes, no medical purposes, and context reflects current published evidence of international guideline recommendations. And as I already been introduced, I'm employed at CeGaT, a genetic diagnostic provider who works globally. So here's the 5 objectives of my today's desk. So first of all, we'll start with understanding of biological basis of precision oncology. We will describe a little bit genomic landscape of lung cancer. I will explain you what's next generation sequencing detects. We will define the scientific and regulatory criteria for distinguishing high quality laboratories and how we can apply these criteria to evaluate genomic testing in real clinical practice. So first, this is fundamental biology. Oncogene addiction explains why targeted therapy can work dramatically better than chemotherapy. The key point is that cancer cell with, for example, EGFR L858R depends on EGFR signaling. So completely that blocking it with osimertinib causes the tumor to collapse, even though the cells have many other mutations. Passenger mutations looks like a noise, and identifying the true drivers requires expert bioinformatic variance classification. The 3 pillars framework from ASCO organize all current precision oncology approaches. So here you can see the timeline, to illustrate the discovery of targets. So in 20 years, lung cancer went from one disease-treated platinum doublet to a collection of molecular subtypes. I would like to remind that previous presenter also shows you how the amount of targets increased during the research on lung cancer. And the key aspect that 2 patients with lung adenocarcinoma sitting on the same clinic may have the EGFR mutations or KRAS mutation or ALK fusion. And this requires completely different treatments. This is why biomarker testing, genetic testing, is critical. real-world data shows fewer than half receive all required tests. This is a gap that comprehensive genomic profiling closes. So each alteration type has fundamentally different technical requirements. Fusions are most commonly missed in narrow panels, yet ALK, ROS1, RET, and NTRK fusions are all approved therapy targets. MET exon 14 skipping requires intronic coverage, not provided by coding-only exon panels. DMB requires a panel spanning more than 1.5 megabases of the coding region to provide accurate calculations, which is clearly shown on all recent publications. A lab that only reports SNVs or hotspots missing multiple clinically actionable categories. On this slide, presentation of comparison, table of comparison builds a scientific case for comprehensive genomic profiling. The tissue arguments is particularly powerful for oncologists dealing with a small endobronchial or CT-guided biopsies. Running multiple sequential tests exhausts limited material, sometimes leaving no tissue for retesting at progression. And this is really critical. The turnaround time argument addresses clinical urgency. The guideline compliance posed most an argument. A single CGP order satisfied all requirements, ESMO or NCCN, simultaneously. So this is like how standard journey of a lung cancer patient. So day one, for example, test ordered for EGFR via PCR. After half of a month, test ordered for ALK, ROS1, RET, MET. Next step, third step actually, test ordered for MET exon 14 skipping using quantitative PCR. And then we are moving to the focused tumor lung panel. And what's in the end? We lost a lot of time, we spent a lot of money, we lost the time for the proper treatment, then we faced with poor outcomes, and we still lost of germline investigation. So family and science miss it. So in general, patients need to wait from 6 to 8 weeks and actually will receive incomplete picture of their disease. So what's the offer of comprehensive genomic profiling? So they first request for comprehensive genomic profile. And after 1 month, even faster, reports with all possible for the patient. And we close several gaps. So we save time and money of the patient, and not only patient, but also public insurance or insurance company or hospital. So we cover all important genes, all important parameters like a TMB, MSR, HRD. We discover the germline variants, and we discover pharmacogenetics. So this is like a practical implementation guide. The key point here is reflect ordering. Play the CGP order at the time of biopsy, not after waiting for histology subtype result. This reduces the overall time from diagnosis to treatment-ready genomic data. Emphasize that the structured clinical report is what converts sequencing data into treatment decisions. A variant list without clinical interpretation is not clinically actionable. So let's discover these slides more in details. So what's critical? So preparation of formalin-fixed paraffin embedded block it should be prepared using the guidelines. Then we at laboratory extract DNA and RNA. Using the validated methods, we perform NGS using validated sequencing platform. We provide the bioinformatic analysis and quality controls for each steps, and they also should be accredited. And of course, we need to perform tumor normal comparison, because it will guarantee that we will not be linked with the tumor contact of the FFPE block. Because we cannot guarantee that the allele frequency, which we will show, will see at the report, really shows the real, is it real somatic or real germline variant? Only real physical comparison could allows us to deliver you the information, is it true somatic or true germline variant? Then important thing is a variant classification. So we need to use the common, like ACMG, AMP criteria. So we need, again, to distinguish somatic and germline variants, because different variants can have different therapeutical strategies. We need to detect really actionable drivers. And we need to review all variants of unknown significance. Important thing for every clinician is a structured, easy to read report with clear indication of TMB, MSI, HRD, the possible pharmacogenetics consequences, toxicity or resistance, and the treatment decision, of course. So there should be some recommendations on the way to immunotherapy or combined therapy or target therapy. And here, this slide maps each CeGaT service to the clinical stage. So we are offering the seamless continuum of the genomic support from the first biopsy to the long-term surveillance. This service portfolio aligns precisely with what ESMO and NCCN recommends at each stage. Adaura makes early stage profiling of EGFR essential. Liquid biopsy fills the gap with the tissue is unavailable. ESMO and NCC recommends comprehensive biomarker testing and diagnostics of advanced lung cancer patients to guide first-line treatment. ESMA endorses CT DNA liquid biopsy as a complementary and to tissue testing, particularly for detecting resistance for mechanism. And here our portfolio, and here you can see that we close all questions, all ways which could be used for every lung cancer patient, starting from the comprehensive genomic panel, name cancer precision, and with MRD testing. And I will go back to the report. So we really proud how our report looks like, because physician, once he obtains the results, will have quite comprehensive reports, but we separate the most important things in the beginning of the report. So now you can see the extract from the first page. All relevant information here. Very clear. And in the end, you can see the treatment recommendations. So that's it. If you can have a look into details, you can read reports, all of the pages of the reports, but most important on the beginning and in the end. Really easy to understand the results for each patient. And in the end, we are offering at CeGaT our vaccine treatment. Let's introduce me a little bit for clinical case and why liquid biopsy testing is really important. I will remind that we are also ordering the liquid biopsy testing using our cancer detect test, or even using the comprehensive panel, Cancer Precision. You can order the liquid biopsy testing for 800, 700 genes. Yeah. So what's happened here? So 42 years old female patient with metastatic non-small cell cancer, EGFR mutation detected in primary tumor, and relapse after initial response. Then we perform the LB testing using urine cancer detect and detect the EGFR mutation. Yeah? And that's why we recommend physician and physician prescribed inhibitor of EGFR gene. On this slide, I will show why lab quality is clinically critical. The Moon et al., so the study, you can see the link, is particularly powerful. 4 certified NGS service providers showed 16.3-fold difference between in detection limits and 4,280-fold difference in FP error rate, all using the same reference samples. This is not theoretical concern. The clinical consequences are direct. Wrong therapy, missed therapy, toxicity, or disease progression. This motivates the next slide on what makes a quality lab. Solid tumor and normal tissue match testing is a method of parallel DNA sequencing of solid tumor and normal patient sample, so blood or saliva, or even FFPE, which contains normal tissue. That distinguishes somatic and potential germline alterations, aiding in treatment decisions. On this slide is the scientific heart of the sessions, actually laboratory heart. So as you can see, so what the question should be addressed to the laboratory. Is the lab accredited? What exactly inside the panel? What the information will receive the physician? If the real tumor normal matching, what the limit of detection for each sample type? Does the bioinformatical pipeline fit the international criteria and includes ASMG variant classification, for example? Does the lab participate in external testing, like CAP or Acquia? What is the average turnaround time? Is the report oncologist facing with clear treatment implications and clinical evidence classification? And yes, CeGaT fill all of them. So we are CAP accredited, clear certified, we have US standards and licenses, both ISOs, not only for medical, but we are reference genomic lab. And see, here you can see how we fit all these 8 questions. Perfectly, actually. So this is like my last slide. It's just a summary of all previously shown slides. And I would like to thank you for your attention. And sorry, there's like a strong echo.